You're listening to Viewpoint, a podcast of Highlands Church. Hey, welcome everyone. We're glad you're here. I'm Brendan Anderson, the weekend services pastor here at Highlands Church. This podcast is designed to equip the church to follow Jesus in the midst of challenging issues we're going to encounter every day in our culture. We do that by looking through the lens of the Bible that we believe is God's Word. And so I am joined today, as always, by our pastor of adult education, Joe and Franco.
Brendan, a delight to be with you as always.
Yeah, and today we are talking about the very light topic, sarcasm intended, of physician-assisted suicide. This is something, man, we are hearing more and more of in the news as lots of countries are getting real bold with their stance and intention to just go full force with this type of thing.
Yeah. A very important topic for Christians to understand, so much so that we're going to actually devote 2 podcasts to this. And it's not just other countries. Increasingly, campaigns are being run in states to bring physician-assisted suicide, by legislation to states. The U.S. Supreme Court said in 2 decisions, there's no right to that under the federal Constitution. So it's now become a political battle state by state. And the campaign for this is stepping up. So we want people to really be equipped to understand this. And I cannot think of a better guest than our good friend, Dr. Jim Benecke. And he has been a guest with us before. And Jim, it's a delight to have you. Why don't you tell our listeners a little bit about yourself again?
Certainly. Thank you, Joe and Brendan. It's a privilege to be here. My name is Jim Benecke, and I am a physician. My specialty is otology and neuro-otology. I retired from my full-time practice about a year and a half ago. I still do some consulting work, but I have a real interest in sanctity of life issues, and so this fits right in there. I've had the privilege of teaching on this many times, and so I'm delighted to be here and engage in a conversation that is so important for the church, so important for followers of Christ to really understand and to know what the Bible has to say about this. We have a source of absolute truth, and we want to look at that.
Well said. This is a rather complex subject. There are a lot of parts to it. So why don't we begin with this part? Jim, I know you're a man of God. You know the Scripture well. You trust in the Lord. Let's start with something like a theology of life. What does the Bible teach about life? Why is this a subject in which we should be engaged?
Yeah, that's an excellent question, Joe, and a great place to start, because we need to understand what God's Word, His inerrant, infallible, all-authoritative, all-sufficient Word has to say. And it clearly tells us that we are His image bearers. Men and women have been created in the image of God. Therefore, there is worth. It is phenomenal worth. There is dignity, and this stretches from the moment that life begins with, which is at conception, until the very end of life, at the end of life issues. So we have this continuum where every aspect of our life, it is created in the image of God, and therefore it is sacred. The Bible also speaks to the issue of the taking of a life. And of course, the issue that we're talking about today is strictly forbidden by God's Word. And we have put our faith and trust in that Word, and so we ascribe to that as an absolute moral imperative. Thou shalt not murder. That's the 6th commandment in Exodus chapter 20. So this is a vital issue from a theological standpoint, looking at man as created in the image of God.
Yeah, that's so well said. And as you're saying that, it's occurring to me, this is not really a standalone issue. When people use, the term life, we like to talk about life issues. Most people probably instinctively jump to the subject of abortion. But really, it's a much broader subject, isn't it? It has to do with issues when we come into this world. It has to do with how we leave this world, and even through the course of life. How do we treat people who have, particular disabilities or special needs or whatever's going on? There's a unifying principle to this, and that is, since we are image bearers of God, that should be a kind of default thinking in any ethical question that we address.
Absolutely.
And the way that people leave this world is a very significant part of the discussion, because increasingly people are viewing this now as kind of a subject of, well, this is compassionate. We're helping people to die in a dignified way. but there's actually a lot more involved than that, isn't there?
Absolutely. And obviously, because we're talking about physician-assisted something, this means that the medical profession has an involvement in this. And that's one of the reasons I have an intense interest in this. And that involvement begins with conception and all the prenatal care that goes on with that, and all the way through life, and how we manage illness, disease, whether they be mental illnesses or actual physiological illnesses. So vital questions, vital topic here.
Well, let me start with a question that I think a lot of people would ask. Let's take the person who is has a terminal illness, and the doctor says to them, well, you're going to last 1 month without chemotherapy, or you'll last 2 or 3 with it, but you're going to be in a lot of pain. And the person says, okay, I'm going to withhold the treatment. Is that essentially the same thing as physician-assisted suicide? You're turning down treatment that's available. Some people tend to think of that as the same kind of issue. Is it? Is it not? And if not, why not?
No, that's a very good question, and I think definitions are crucial here to understand exactly what we're talking about. But somebody that refuses treatment because it's really not going to provide a quality of life or a quantity of life, that's an option that patients are given. And every oncologist of integrity will offer that, will oftentimes tell the patient, well, if you don't take the treatment, this is what's going to happen. But that's not the same thing. If a patient refuses to undergo treatment, knowing full well that the end is in sight, that's not the same thing. Nobody is administering something under these circumstances that would hasten their demise or cause their immediate demise. So that is an informed decision patients do have the right to make, and oftentimes it is the best choice. I think one of the issues, and I know we're going to get into this in greater detail, one of the arguments for physician-assisted suicide is that modern medicine doesn't have the means to cope with the amount of pain and discomfort that patients are experiencing with these terminal illnesses, and that just is not true.
Yeah, a lot of the discussion we hear from proponents of physician-assisted suicide uses words like compassion and dignity. In the old days, you kind of got what they were about. I want to take my life. They have, organizations had names like the Hemlock Society. Now, probably not many people get the reference any longer because I don't think many people read Socrates these days. But this is a very intentional thing, isn't it? To shift the focus from let's bring on death to let's do something that's compassionate for people, that helps them die in a dignified way. Do you have thoughts on that, on the language that's used?
I do, Joe, and we've talked about this many times when it comes to the abortion issue, that the label on the box doesn't necessarily fit the contents, and these are code words. The state of Oregon, I believe, was the first one that legalized, that codified into law, physician-assisted suicide or physician-assisted death. I think it was called medically assisted death at that time, but it was part of their Death with Dignity, Compassion to Die Act. And it's interesting because we use the word dignity as we just at the very opening of this, that we believe life has dignity. And there is nothing dignified in the lexicon of the Christian about enhancing somebody's ability to die quickly, to assist them in death, to assist them in suicide. So we use that term differently. But these are code words for basically the taking of a life.
And before we get into some of the nuances of exactly what's going on in the midst of physician-assisted suicide, much like Joe just pointed out, the idea of a patient refusing treatment is not what we're talking about. I want to also be clear, we're also not talking about a situation in which a patient, family member, would pass away would it not be for the intervention of different machines. I mean, the classic insensitive term is pulling the plug, but we're not talking about situations in which somebody would not be able to live without intervention.
That's exactly right, Brendan. And of course, that is not physician-assisted suicide. When sustaining life, when withdrawing life support is done in a humane, compassionate manner, because it's clear that life is not going to survive without some sort of mechanical assistance. So we do have the ability, praise the Lord, we have the ability to determine brain function with a high degree of accuracy these days, so that we can really give the families the outlook, the prognosis. Is it worth continuing down this course, or is it just going to end in the patient's demise and just a lot more agony for the individual and the family? So that's an entirely different category.
There are sometimes very difficult hypotheticals. I've heard of cases where somebody no longer has brain activity. And I'm talking about true flatline. There have also been a lot of cases. I remember when I was practicing law, we had people come to us and they're going to terminate the life of my relative or this or that. And it turned out there was brain activity, and it was more of a quality of life issue, and somebody wanted this person gone. It might have been for insurance purposes, who knows? You get into a deep well with that. What if somebody comes and they say, okay, all artificial machinery has been removed, and we thought the person would stop breathing on the room when that happened, but that's not what resulted. The person is now laying, in bed. There's no brain activity, and they can be kept alive for a long time through whatever, intravenous, solutions or something. What happens in that case? How do you look at that?
Well, thankfully, I think those are, really the far end of the bell-shaped curve exceptions to the rules. Although possible, Joe, I think the likelihood if somebody is requiring mechanical support, mechanical ventilation, and that is withdrawn, the likelihood of them lasting long without it, or sort of having a second wind, no pun intended, after it's withdrawn is very unlikely. But if that were the case, then obviously those that are given the charge of the medical care would have to reevaluate the situation and determine, okay, is perhaps there going to be sustainable life here, even in the absence of mechanical ventilation? And then what do we do? More or less a comatose situation.
And I ask the question maybe just to make this point. And that is, you began talking about a theology of life. We're told murder is wrong. We are image bearers of God. There may be difficult situations that arise, but there has to be an organizing principle. There has to be a way we evaluate it. And the organizing principle has to be life has value. We don't hasten death. So even if people come up with difficult hypotheticals, it might be a fraction of 1%. There are still ways we can organize our thoughts, look at biblical principles, and say, this is how we approach it. What do you think, Jim? What's the principal harm with physician-assisted suicide? Putting aside the biblical arguments, which we get, in terms of just how it impacts society and families, what are the big issues that are implicated by that?
Well, it's sort of a turning on its head. We believe in the sanctity of life. It's almost the sanctity of death, that perhaps the individual is more valuable in death than in life. And of course, we know what's happening. I think it's in the UK, they have this Trillium Society where they're actually looking for organs to harvest while patients are still alive, and then of course they undergo some sort of physician-assisted death. So it's a very, very slippery slope. And then you think about people sort of at the extremes, the margins of society, those with mental illnesses, those with dementia, and so forth. That's where the harm comes in. To me, there's this irony, because here we have this whole society that seems to be bent on suicide prevention measures, and now we're promoting it. I mean, it just seems like an oxymoron. Yeah, and we have the means to deal with depression and dementia to a certain extent. And so there are some real dangers and some real harm that come into that. And again, convincing a patient that, well, donate your organs. You've got a good heart, good kidneys, 2 good lungs, retinas are fine. That'll be valuable. You'll be of more value in your death than in your life.
Yeah,
that's a very dangerous position.
You've hit a lot there. Let's try to take some of that apart. The organ harvesting is a very serious and real issue. I have friends who have been involved in legal issues in China, and they say it's far more common than anybody realizes. China executes, I don't have the exact number, but a high number of individuals every year. I believe more than any nation in the world. And apparently there's a regular system set up where when young, healthy persons are executed, the organs are preserved, and there's some hierarchy. Who knows? It wouldn't surprise me that government officials are at the top of the list. but that's become kind of a cottage industry there. But let's break down a few things that you went into. Let's talk about pain. There's a kind of perception, or you'll hear this discussed in the debate, that we're doing something, insensitive, or we're doing something mean when we don't let people end their suffering. Tell me about where the medical profession is at now with that. What's the state of palliative care? Where are we at with suffering?
Yes, that's a very good question. Of course, I have very close personal experience with this. Our son, who died of cancer, was on hospice for 5 weeks, and the type of cancer, osteosarcoma bone cancer, causes intense pain, and yet we were able, with the assistance of our hospice team, to keep the pain under extremely good control. Our son didn't suffer. Now, there comes a point in time when the management of that pain really will override the ability of the patient to really stay conscious. But that's getting near the end anyway. So our ability to manage pain has improved dramatically. It's just like our ability to manage nausea with chemotherapy and so forth. There was, the argument for we have to legalize marijuana for that. And, our son went through 64 cycles of chemotherapy over the course of 6 years. And I can tell you that the drugs that were available were wonderful. I mean, he had some intense nausea from some of these horrible treatments, but we have the ability to do that. And it's the same thing with pain these days. And it really requires skilled, compassionate individuals on the medical team to manage this, and it can be done. We have the wherewithal to do this. We're not throwing up our arms. There's nothing that can be done. We're watching you suffer. We're suffering watching you suffer. We're just going to put an end to it. That is not at all necessary.
Yeah, the U.S. Supreme Court considered the question of physician-assisted suicide on 2 occasions, and both occasions said there is no right under the federal Constitution to physician-assisted suicide. We mentioned that earlier. One of the notable things in those cases is there were briefs filed with the court that focused on the subject of palliative care and suffering. And I remember seeing a few of those briefs, and it kind of surprised me because the writers of those briefs, and they were various, medical professionals, made it sound almost as if we can pretty much manage all pain, that pain becomes a non-issue with terminal patients, that we've reached that point in caring for pain. Would you agree with that assessment?
I would agree completely. Absolutely. We have gotten to that point. We have people that specialize in nothing but pain management. When our son was a patient down at MD Anderson Cancer Center, there was always a pain management specialist involved with his care, and they were absolutely remarkable. Let me make just a little distinction here, Joe, in terms because we talk about palliative care and end of life care. They're two different things. So palliative care, we would say, somebody has a cancer that's no longer responding to treatment. That's one place where palliative care might come into play. They're not really close to death, but it's just nothing is working. They're
controlling pain longer term.
Their cancer has really not responded to treatment. So yeah, we give them pain control and so forth, and they may last for a long time. We had friends, that had ovarian cancer or something, recurrences, and there was really nothing that they could offer, but they could palliate them, giving them something. But that's different than end of life, when we know the person, we've exhausted all possibilities, are getting close to the end, and then we provide a different form of treatment for that. But I would agree with the statement that you made that we can definitely manage pain very, very well. And again, close personal experience with that has taught me that is that's an axiom. Yes.
In countries that we see this being extremely common now, this physician-assisted suicide, particularly Canada, I've been reading a lot of articles about. Do you see the role of doctors? I mean, there are a lot of scenarios that certainly would come up if you're a doctor who is a Christian and has a view of life and saying, I can't take part in this, and yet the medical profession of whatever country you're in, and if it comes to the United States and becomes just as widely accepted here, where are doctors going to fall or be responsible for? Is it just, I'm going to have to get out of this whole profession because I can't take part in something that goes against?
That's an excellent question, Brendan, and I get asked that question frequently because what we're asking physicians to do under these circumstances is change from being a healer to an executioner. And that is not, We go into this field to save life, to promote life, to improve life at all stages. But to answer your question, Canada's already dealing with this. The application process is going to screen out individuals that say, I would never do an abortion. Of course, they ask me that question. Well, I do ear surgery. Of course, I'm not going to do abortions. But they want to know your ideology and where you stand on the physician-assisted suicide issue. Canada has just gone over the top. I read a report recently, 2 Canadian physicians, one of them has, I think within the course of the last 12 months, has executed 400 patients, the other one 300 patients, and they were giddy. Like a surgeon might say, I've had 400 successful hip replacement. I've done 400 successful hip replacement procedures. I'm really proud of that data. They were proud of the fact that between the two of them, they had executed 700. But I think it's coming soon to a theater near us where that will be part of the application process in medical schools in America. Where do you stand on the management of terminal illness with respect to physician-assisted suicide?
Yeah, we've actually already reached it. There are already cases being filed. Some of them are starting off kind of on a lower level. I'm in a state-run medical school, and I'm told that I have to go through the abortion segment. I've asked for a conscience exception. I don't want to go observe an abortion. I don't want to learn about it. I will never do one. And we're already seeing the first clashes where the students are being told, even if you don't do it, you have to learn about it so you know how it's done. And there are now the first wave of cases are forming in states where a physician assisting with physician-assisted suicide is being told that he or she must provide that care. Lawsuits are coming on that. And this is the intersection of conscience and, the state's program and compelling people to be a part of something. That's come up in a lot of context. And now it's coming to the medical profession. When I was in my former place of employment, we actually created a division on conscience rights for medical professionals. And it was happening. We represented a number of nurses in New Jersey and New York who were actually compelled to assist in abortions. Both lawsuits were successful. Both hospitals were told you cannot compel medical professionals to do this if they have a religious conviction. But that doesn't discourage the other side. I think we're going to see those coming, and they will come as well on the subject of physician-assisted suicide.
Yeah, and I think we're gonna take on a lot of that really in our next segment of this. As Joe mentioned at the top, we're going to go into a part 2 because there are so many elements of this. So really to kind of start capping off this first part, talking and introducing the topic, I would be interested, Jim, just as a doctor and looking at this with the experience that you have, let's dial back. You've got a person that or maybe it's a friend, acquaintance, somebody, maybe even somebody in the church, not in the church. They have a relative who is old. They have something that they've lived a long life. They're saying, hey, look, they've lived a long life. They're going through intense suffering and pain. They've done everything they've ever wanted to do. They've just reached the point where they're just done. I mean, who is it hurting to just let them do what they want to do? What would you say in your experience to something like that?
Yeah, I mean, when somebody would ask me that question, I would sort of wonder, why are you asking it that way? Almost asking for permission to end this. Well, it doesn't hurt anybody. Well, it might hurt another family member that would love to watch them. I think about my mother-in-law is going to be 99 years old in July of this year. And, she's got terrible dementia. She's in a memory care center, but she's very happy. Very happy. And so I look at situations like that, but I also look at her as she's created in God's image. And I could never endorse, just give me a shot, as some people would say. I want the shot. Oncology friends of mine have said, they've had patients come in, doc, just do it. Well, it's not legal in our state, so I can't do it, but I wouldn't do it anyway. I don't, asking what harm is it? Well, the harm is to the image of God, to the image bearer of God. That's how I would answer that. And of course, I might get met with as my wife says, a styrofoam head look, the blank stare. Well, I don't believe in that. So I would want to explore that further in terms of, are there other family members involved that are participating? Have you talked to the individual, the one that's actually going to be on the receiving end? Do they have enough cognitive ability to really understand and comprehend? And that's where we get into trouble. We'll probably talk more about this in the next segment in terms of dementia patients filling out advanced directives, basically giving carte blanche to their providers to do whatever they want when they get to a certain stage. So, where do we draw the line?
Yeah, that's a great point. Let's return to a subject you touched on peripherally, and that is the role of the doctor as healer. Do people still take the Hippocratic Oath seriously?
Well, I've researched this extensively, and it's really hard to find factual information on this. And I couldn't find one medical school that still uses the original or a slightly amended version of the Hippocratic Oath. Initially it was funny because I was asked by somebody, well, you're a follower of Christ. Did you take this oath when you were in medical school? I swear by Apollo, the physician, Asclepius, the surgeon, and so forth. And I said, well, we took the Hippocratic Oath, but they took that part out. They left that out because they knew that it would bother some people to swear by Roman and Greek gods and so forth. But do they take it seriously? I don't know. Almost I think every medical school, they have these white coat ceremonies when you first start out in medical school and then when you graduate, and they take oaths, and the oaths are wide and varied, but hardly any of them bear any resemblance to what we actually see in the Hippocratic Oath, what we are dedicated to do no harm and to not give patients injections or medications that will kill them.
And I, of course, was not referring to so much the oath literally as the spirit that embodied it. Yeah. You're a physician. People look at you and they say, this is the person I'm going to for healing and help. When you look at a terrible perversion of that, you could look at Dr. Joseph Mengele in Nazi Germany. Some patients are getting care and other patients are the subjects of experiment and how much pain you can take before you die. We look at that as a natural horror made worse by the fact that this is an educated person who is kind of sworn to help people, and they're using that skill in this horrible way to measure things that we would universally condemn as bad, as evil. So there is still that concept that you are the healer. Do you see that as some kind of issue here, that when the patient goes to you or the patient's representative, now when you're looking up the table of options in front of you, well, I can treat them this way or do this or do that, or I can end their life, with this injection. What does that do to you or to the physician in that role as the trusted person and the healer?
Well, I would think that would have a severely damaging impact on the trust that you would gain, because most patients do come to you looking for compassionate care, improvement in the quality of life, Joe. So that's what I would think. I found this. This was, I can't remember the year this was published, about 6 or 7 years ago. It's called Professional Integrity and Physician-Assisted Death. This is what the authors say: the practice of voluntary physician-assisted death as a last resort. Now that's changed. I mean, it's not a last resort today, is compatible with doctors' duties to practice competently, to avoid harming unduly, to refrain from medical fraud, and to preserve patients' trust. It therefore does not violate physicians' professional integrity. So this is a paper that was written that is quoted often in terms of justification for, it doesn't violate the patient's trust. Of course it does. I never had a patient come in to see me in the 40 years that I practiced medicine asking me to make them worse. They want us to give competent, professional, well-researched care to improve and prolong life.
What about the person who asks you, isn't it more compassionate to take the person who wants to die and to help them do it in a safe, I retract that word, to do it in a clinical way, because if you don't, they've already said, I'm going to kill myself. Instead, they're going to go out and try something else. They'll take pills. And should we allow people, for the sake of personal autonomy, to have that option if they're determined to die anyway.
Well, that's one of the arguments from the side that they're proponents of physician-assisted death. Well, if you don't do it in the right manner, then they're going to do it on their own. That's almost like saying, well, I'm going to give my children fentanyl in the basement because, after all, they're going to probably get it from their friends at school. Let me do it under a controlled setting. I mean, it's just, I think, that's really an abomination to look at it that particular way, because it's, and the other thing is, when somebody says that, yes, I really want to die, how seriously are we taking them? Are we looking at the mental side of this? Is there something that we can do that would help them no longer want to die? That we could get them to look at the dignity of human life, even at the very end of life, even when the chips are down, when the wheels come off the cart? Is there something that we can do to really give them a realistic outlook of what life is like, made in the image of God?
Yeah,
and make it worthwhile.
Well, I'm so glad to hear you say that. And it strikes me as one of those false arguments. You don't have to dig very deep in order to see the fallacies behind it. How about when somebody comes to you and says, I'm tired of living, I want to die? What about diagnosing the person's mental health? What's wrong with you? Are you depressed? There's treatment for depression and all of that, rather than this default, well, this person wants to die. So that suddenly gets pushed to the front as if that's the thing we have to do now. So it really is a kind of a false argument, isn't it?
It really is. I mean, obviously, in the medical profession, we've been dealing with depression and people that have suicidal impulses forever. And of course, we look at suicidal prevention and medications. And I know some people that severely depressed and had attempted suicide, and they get put on the right medication, and they tell me it's like there was a piece of my brain missing, and they put it back. And I feel so good. I love life. So it's making a false assumption, Joe, as we've said, that there's nothing that we can do, and it's just short-circuiting the whole process.
Let's close this session with a little more theology. Jesus looked at crowds, and it says that he saw their suffering, and he saw that they were hungry, and he said to the disciples, I have compassion on them because they're like sheep without a shepherd. Jesus talked in Matthew chapter 25 about caring for the least of these. So we find there's a Christian ethic that really, historically, drove the creation of the medical profession. The first hospitals were started in the Middle Ages by Christians and all. There was this sense of wanting to care for the vulnerable and all of that, again, as an extension of our beliefs as Christians. So any closing thoughts on that or along that line?
Well, the joy that I received in 4 decades of practicing medicine was providing relief and help for those that really needed it and were unable to find it anywhere else. And that's one of the things that worried me about full-time retirement, because it really did define me. That's what really defined me in terms of my desire to help others and to go at whatever length I could to improve the quality of life. And of course, I wasn't a believer when I started out in my medical profession. I was saved at age 49. Age 47 in 1999, and it changed dramatically. It was good before then, but I realized this is the image bearer of God, and I have a duty, and it's a joy and a privilege to be given these tools and these abilities to do that.
Yeah, that's such a great perspective. Well, there's so much more to say on this, and that's why we're gonna dive in a part 2 that we will release shortly after this one, so that we can look at even more angles, talking a little bit about what's going on in countries, a little bit more that we see already. What consequences are we seeing in societies that are embracing physician-assisted suicide, and the implications of that, what it means to different people groups as we look through, and then really bringing it home to how Christians should and can be thinking about this and interacting with this issue as it reverberates through culture. So we're going to be back with Jim for another segment of this. But as always, if this episode has been helpful for you, if it's a resource that you think might benefit somebody else, please share it. Subscribe to Viewpoint if you haven't already on your favorite podcast app, and let others know as we continue to walk through these cultural issues, looking at them from God's viewpoint through His Word. And we will see you next time.